Hello, everyone. Welcome back. Welcome to Drug Exam number 18 lecture, where we talk about medications that are given for respiratory complaints. There are several medications. Some of these medications are going to be given IV. Some of them are nebulized, even in drip infusion here in this chapter or this section, whatever you want to call it. But let's get to talk about them. First one we're going to talk about is albuterol. Albuterol is not a new medication for us. We know that it is a beta-2 agonist, so it is a smooth muscle relaxer. We would give this to a patient who has bronchospasms, wheezing, asthma attack, those types of things. It causes a widening of the airways that will allow air to more readily pass through the airways. The dose for it is 2.5 milligrams, and it would be nebulized and given it inhaled, set at 6 to 8 to 10 O2 infusion rate, or O2 level rate. Next medication we're going to talk about is Decadron. Dexamethasone is the other name for it. It is a corticosteroid, and its main job when it comes to respiratory complaints is it suppresses acute and chronic inflammation. So when we have someone who has an asthma attack, asthma is not just bronchoconstriction. It is bronchoconstriction with the inter-airway inflammation of those bronchioles. So you have two different mechanisms working to close that airway and make that wheezing occur. We are going to be using Decadron or Solumedrol to reduce that inflammation. Now, Decadron and Solumedrol are used pretty interchangeably. They work very similarly. The real only difference between Decadron and Solumedrol is that Solumedrol is more for the acute patient, where Decadron, it takes a little bit longer to work, but it is better for the long-term treatment of chronic inflammation. So they're almost used interchangeably. A lot of agencies will only carry one or the other, but we kind of need to know both of them in this situation. So for Decadron, the dose is 0.6 milligrams per kilogram given IM, IV, or IO. And it works. It's not something that's typically going to work for us in the EMS setting. It's something that will make the patient feel better over the next course of 30 minutes or an hour. Depending on our transport times, we might actually see the effects of that, or we might not, but it lasts for a long time. The next medication we're going to talk about is Atrovent. Atrovent is also known as ipratropium. You're probably a little more familiar with it being called that. And ipratropium is that second part of a duoneb. We know that albuterol and ipratropium given together is called a duoneb. It's kind of like a 1-2 punch for respiratory problems. So they work similarly, but not exactly. So I said earlier that albuterol is a beta-2 agonist. It causes bronchoconstriction. What ipratropium does is that it works by preventing bronchoconstriction. That's slightly different than causing bronchodilation. It prevents bronchoconstriction and also reduces mucus production. So when we give someone a duoneb and we give them Solumedrol or Decadron, we're kind of hitting them from three different directions. We're hitting them with a powerful bronchodilator. We're giving them a medication that reduces mucus and bronchoconstriction, and we're also giving them a medication that reduces swelling. All three things with the one intended purpose of making those bronchioles bigger to allow more air to pass through, to allow that air to pass and to cause better oxygenation of the cells. The dose for ipratropium is 0.5 milligrams nebulized, usually given in conjunction with that 2.5 milligrams of solumedrol. Excuse me, that 2.5 milligrams of albuterol. My apologies there. Next medication we're going to talk about is solumedrol. Solumedrol is also known as methylprednisone, and it is another corticosteroid, and it causes a suppression of acute and chronic inflammation. And so it is kind of used in the same manner that Decadron is used for. But I think typically what I've seen is that more agencies will carry solumedrol than Decadron, but some agencies carry both. Decadron also has a use for decreasing intracranial pressure, so a lot of agencies will carry it for that. But in this situation, solumedrol is kind of more the go-to for this type of treatment. Now, most protocols will tell you that the adult dose of solumedrol is 125 milligrams given IV. In this drug exam for this course, the dose for solumedrol is 4 milligrams per kilogram, not the full 125. Sure, I missed anything. And remember that the difference between Decadron and solumedrol is that solumedrol has a little bit faster action, where Decadron kind of works a little bit longer than the other. The next medication we're going to talk about is Xopenex. Xopenex is also known as levalbuterol, and it works in a very similar manner to albuterol. It is a beta-2 agonist. It causes bronchodilation. The only thing that's really different about Xopenex versus albuterol is that you don't see those conotropic effects that you see with albuterol. That meaning that you will not see that increase in the heart rate associated with administration of albuterol. Xopenex is that's the big benefit to it. So if you have someone who is tachycardic, maybe they're very anxious, very fidgety, and Xopenex might be a better choice in that situation because it doesn't have those other effects that albuterol sometimes has. Xopenex is given 1.25 milligrams in 3 milliliters of normal saline, and it is best given nebulized. It is given nebulized. We don't give it IV. It's just given nebulized. Next medication we're going to talk about is not a new medication for us, and that's mag sulfate. Mag sulfate is a powerful vasodilator. It is a powerful bronchodilator. So this is something that we would give to a patient who is having a acute respiratory event. This would be given IV infusion over 10 to 15 minutes. This is not something that's inhaled. That is not something an IV push. It is infusion. Typically what we do, whatever the doses that we are going to administer is, we would put that into a 100 milliliter bag of IV solution, and then we would infuse that over 10 to 15 minutes with macro tubing. So in this situation, the dose is 40 milligrams per kilogram IV infusion given over 10 to 15 minutes. Now, some places will say 4 grams given over 10 to 15 minutes. And for your 100 kilo patient, that's tomato, the same thing. But the dose is 40 milligrams per kilogram IV infusion given over 10 minutes. Be careful with giving this to someone who has a soft blood pressure, and do not give this to someone who has a low blood pressure because, like I said, it is a powerful dilator. And if you have somebody who has a soft blood pressure, they are now going to have a low blood pressure. And if someone has a low blood pressure and you give them mag sulfate, they are going to have an, in fact, even lower blood pressure. And if that were to happen while you're infusing mag sulfate, you might need to shut it off completely or slow it down to give it over a little bit longer time to prevent that hypotension. The next medication we're going to talk about is racemic epinephrine. Racemic epinephrine is given for a patient with croup. And so what happens is when we give it nebulized, it will be inhaled and create the reduction in that airway swelling that causes stridor. We don't give it for epiglottitis. And really the difference that we're able to differentiate between croup and epiglottitis is traditionally croup will have that barky cough, and epiglottitis will have stridor and drooling and leaning forward. That leaning forward, drooling coming out is typically with epiglottitis. Dose for it is 1 milligram nebulized and mixed into 2 milliliters of normal saline and then nebulized. It doesn't really have an effect on the lungs though. So when we are giving it, we're not giving it to open up the bronchioles, kind of like what we typically think of when we think of epinephrine. We are giving it for um, uh, reduction of swelling of that upper airway. The last medication we're going to talk about today is Helinex or helium, and it is given inhalation in a manner that allows the patient to improve oxygenation. Since helium is lighter than air, it improves airflow and reduces resistance in the bronchioles, so therefore it will improve gas exchange. For pneumotoxic patients, we would give them a mixture of helium 80% and oxygen 20%. For a hypoxic patient, we would give 70% helium with 30% oxygen. Now remember that the FiO2 in the world that we live in is 21, 22%, depending on what book you read. But so that 80 and 20 is pretty standard. But for a patient that is hypoxic, we'll give them a little less helium, 70% helium, 30% oxygen. So they're getting an FiO2 of 30%, which is significantly higher than the 22%. But we're also using the helium to reduce the resistance in the airways. So it will allow for improved gas exchange. I think that's all we have for this week. If you have any questions, please ask your instructor, and we will see you next time.